Hi. This week we're going to talk about observational research designs. And observational research designs, particularly in clinical and health services research, are particularly useful. We know that experimental designs where the investigator has control over the type of treatment intervention that people are exposed to, they're considered to be the gold standard in especially pharmacological research, but also in other areas of science. The clinical trial, the randomized clinical trial, is considered to be the trial that can prove the type of research design that can prove causality. But often we can't have the luxury of randomly assigning people to different treatments that were chosen by the investigators. Sometimes we have to go out in the real world, find people who are exposed to a particular type of treatment or a particular type of harm reduction program and study them where they're actually receiving the treatment. The advantage of this is that you're studying people not in a artificially constructed way that was controlled by the investigator, but in the real environment where they're receiving treatment as it is experienced in the real world. Observational research designs with proper controls can be very effective in teaching us what works in treatment and what doesn't work. So let's talk about how observational research designs can be understood. First of all, they are research designs where the investigator doesn't decide who gets the treatment and who doesn't get the treatment. We find a group that is being exposed to a treatment and a group, if we're lucky, a comparison group that's exposed to an alternative treatment or no treatment at all. And we track those people over time to see what the outcomes are. There are two types of observational research design, though. One of them is just descriptive. And often, instead of having a comparison group, we're just describing the people who get the treatment. And descriptive research designs can be useful in planning treatment services, as we'll learn in a minute, as well as looking at the correlations among variables which allow us to describe who is getting access to treatment in terms of their personal characteristics and how we can evaluate the performance of a treatment system itself. So the type of observational research design that we'll now talk about is analytic studies. These are studies where people are exposed to an intervention or no intervention or to one intervention and a comparison intervention, and they are tracked over time in terms of their outcomes. Or you look at the data that is collected from a large cohort of people and you correlate variables that allow you to say something about which people are responding to a treatment and which people aren't. Health services research generally is based on observational research designs. And one key way to study people who are exposed to different types of treatment is in a cohort study. This is a study in which a group of people are exposed to one intervention and compared to a group of people who receive no intervention or comparison intervention. And what we're looking for is their outcomes in terms of how long it takes them to relapse, how seriously their relapse is experienced, and whether there's any other problems experienced by people, including psychiatric problems, mortality, the development of drug or alcohol-related diseases. All of these things can be measured as outcomes. So a cohort study just tracks people over time and compares them to another group who are not exposed in the same way. A good example is the DATOS studies. This is the drug abuse treatment outcomes studies that were sponsored by the National Institute on Drug Abuse. this was a huge study conducted in the 1990s all over the United States with about 96 different treatment programs. Over 10,000 people were recruited as they entered treatment, and a baseline evaluation was conducted on all of them in exactly the same way. So we had a description of their characteristics, personal characteristics, their substance abuse characteristics, as well as the types of treatment that they were exposed to. People were recruited from different types of treatment settings. So these settings were not assigned by the investigator. They were treatment settings that people came into, and we were observing what happened over time when they were exposed to these different treatments. The treatments were outpatient methadone maintenance, long-term residential care, outpatient drug-free treatment, and short-term inpatient treatment. So we have 4 different types of treatment, and we can track cohorts over time in terms of how they responded to those treatments. The outcome data were collected 3 and 6 months after the baseline evaluation was conducted when they came into treatment, as well as 12 months and 5 years following their exposure to treatment. These are data from people across all programs who came in with a major cocaine problem. So the first diagnosis that they received was cocaine use disorder. They could have been using alcohol, they could have been using other drugs. These things need to be measured, but our main outcome of interest would be how they responded to the different types of treatment they received when they were followed up at the end of their treatment and 5 years later. And what this shows is that across all of the conditions where people with a cocaine diagnosis were exposed to treatment, that at the different follow-up points represented in yellow and blue, there was a sharp decline in their cocaine use. And the blue represents their outcomes 5 years later. Looks pretty good in terms of an outcome. There was also an improvement in their health, a reduction in illegal activities, and reduction in their alcohol use. So by any standards, this looks like reasonably good outcomes across the different types of treatment that they were exposed to for a cohort that was tracked over 5 years. The problem with studies like DATOS is that without a proper comparison group, a group of people who can be tracked over the same period of time who didn't receive any treatment, or even if you have a group of people who had a cocaine diagnosis but that got exposed to different types of treatment, whether it's residential or short-term psychotherapy, there are limitations in how we can interpret the outcome data. And a major limitation is the lack of that untreated control group. So even if people are compared to somebody who received a different type of treatment in a comparison treatment, we can perhaps suggest that people who got into long-term residential are doing better than people who got into short-term outpatient treatment. But in an observational study, remember, people are just being observed in the treatments that they got. And the treatments that they got were determined by people selecting themselves into different types of treatment. It could be that people who really needed treatment selected themselves into residential treatment, or they had a lot of money and they could pay for it to go into an expensive treatment service, and they may have done better than people who just selected themselves into outpatient treatment. Another problem is that recovery is likely to occur as a function of time, so that people might be doing pretty well after 5 years, but they would have recovered anyway without any treatment. So there are weaknesses in observational studies that we have to pay attention to. The strengths are that they're being exposed to real-world treatment programs and not programs that have been created by an experimenter, and people can be studied in very large groups with good measures over time. Case control studies are also used in some cases in treatment research, but we're not going to be talking about them because it's not common in treatment evaluation research. So usually in a case control study, you start with an outcome, whether it's death from HIV infection, for example, and you compare people who died with people who did not die, and you go backwards to find out what types of treatment interventions they were exposed to. And you can look at harm reduction programs like needle exchange. You can look at programs where they might have received counseling about safe sexual practices. And then you can look for differences between the group that was exposed to these interventions and the group that was not in terms of the outcomes. Case control studies can then be used to infer what the impact of a particular treatment would be. Another type of study that's sometimes used in treatment evaluation, particularly for generating hypotheses, is the cross-sectional study. These studies are based on an assessment, usually a large number of assessments that are taken when people come into treatment, and they ask people about the different characteristics and symptoms that they've experienced, and they are asked in some cases about the treatments that they've been exposed to. An example would be patients at the time of treatment admission who are asked to report on their current psychiatric symptomatology. And we can measure whether they have a depression or affective disorders or anxiety disorders. And we can also measure the extent of their alcohol use and their alcohol dependence. So once we have these data, we can look for correlations between the number of psychiatric comorbidities and the severity of their substance use disorder. And if we find a high correlation, we can interpret that in several ways. We can interpret it as perhaps suggesting that the psychiatric disorder in these patients was contributing to the severity of their alcohol dependence, in which case we would want to pay a lot of attention to treating their psychiatric disorder. Or we could interpret it as being an indication that people who use substances more intensively develop more psychiatric symptoms, particularly anxiety and depression, which is manifested during withdrawal, and that the drinking is driving the psychiatric disorder rather than the opposite. So one of the problems with cross-sectional studies is that the outcomes of interest can be interpreted sometimes in both directions. And what we would need is either a prospective cohort study in order to sort out the causal direction of these variables, or some other research design that would allow us to make better causal inferences. Another value of observational research is to describe the treatment system and the things within that treatment system that are contributing to better outcomes at the population level. And it can be also used, descriptive approaches like observational studies can be used to characterize the people who are in need of treatment. So what we can learn from observational research is What is the need for services? How can treatment services be made more accessible to the people who need them? What can be done to build community support networks like AA or Narcotics Anonymous? To what extent can medical and psychiatric and prison and primary care services all be coordinated and integrated with formal treatment? And also we can look at the population impact of treatment. So what we can do with observational research is describe treatment systems as they exist and look on a cross-sectional level at the associations between these different variables to develop hypotheses for treatment planning as well as understanding how the treatment program is operating. So I want you to pay attention to your readings, which are going to give you a good introduction to how we can study treatment systems using observational research at the population level, as well as observational studies of treatment programs that can help us to learn on an individual level how effective these treatments are.